Good morning, everybody, and welcome to another Insight APSAD webinar. My name's Jim Hunt, and I'm a nurse educator here at Insight, and it gives me great pleasure to welcome everyone to join us today. Before we commence, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting today and pay my respects to elders past and present. And I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us out there in webinar land. So thank you for joining and welcome. It gives me great pleasure today to introduce Associate Professor Matthew Gullo, who works clinically at the PA in the AOD service there, and also as a clinical psychologist at UQ. And he's going to present today on assessment tools used in youth services particularly. So I think it's going to be quite interesting for a lot of the clinicians to tune in and learn a little bit about what's useful and what might not be so useful from Associate Professor Matthew Gullo. So please welcome him.
Thank you, Jim. It's a great pleasure to be here today. And the title for my talk was inspired by a passage from 1 Corinthians. For now we see through a glass darkly, but then face to face. Now I know in part, but then shall I know even as also I am known. And the first line of that actually is enunciated beautifully by none other than Sir Patrick Stewart in the film Star Trek Nemesis in his iconic role as Jean-Luc Picard. And it's a passage, a sentiment that I often reflect on when thinking about assessment and what it is we're trying to do in clinical assessment. So this idea of reality being opaque and perhaps forever opaque. And in the film, it takes on more of a focus of self-understanding and how difficult that is. So if you take a moment to reflect on your teenage years, how well did you know yourself at that time? How well did you know your true self or the person you would become? What about in your 20s? What about in your 30s? So as someone who's on the tail end of their 30s, while I may know a lot more about myself than I did in my teenage years, I still don't understand why I do half the things that I do. And that's having had a lifetime of access to my innermost thoughts, emotions, values and goals, and still I don't know why I do half the things that I do. And I'm sure that's true of a lot of people, and that takes on a whole other dimension when you think about what it is as practitioners then we're trying to do. So working with people who often are in a pretty difficult spot and are dealing with some very challenging things and trying to understand them in a very short amount of time and to build a plan for how you're going to work with them to enact positive change. So if you're lucky, maybe you get an hour to get a good picture of that person to inform the kind of work you might want to do with them. But most of you probably get a lot less and you don't have access to their innermost thoughts or their emotions. You haven't observed them in their natural environment even. All you have to go on is what they tell you, and often that's in response to questions that you ask them and how you ask them. So the idea of assessment and trying to understand a person and providing a holistic form of treatment is really extraordinarily difficult, a monumental task. And I think we need all the help that we can get. And that's in large part what I want to talk about today is this idea of assessment and tools that perhaps can make that easier, can accelerate that process of getting to know a person who you're wanting to work with to help them deal with problems with drugs or alcohol. So I'll start off just talking some definitions, assessment and progress monitoring, review some of the evidence on the benefit of incorporating standardized assessment tools as part of your practice, looking at the very real practical issues and barriers to using these kinds of tools, and recognizing that there's an endless ocean of tools out there to think about how do you go about thinking about what to assess, even if you're on board with the idea of using these kinds of tools. And then I'd like to talk a little bit about a tool that we've developed at the University of Queensland and the Alcohol and Drug Assessment Unit at PA that we're hoping can hit a lot of those marks of providing some of the benefits, reducing some of the barriers that maybe some other people will be interested or find helpful as well. So just starting off with some definitions. So assessment. There are many ways in which you can define assessment in substance use, but I recently saw a great definition that's going to appear in the upcoming guidelines for the treatment of alcohol problems that I believe Paul Haber's spoken to you all about in this forum. And in the section on assessment, Professors Jason Connor and John Saunders enclose this. Assessment seeks to characterise a person's substance use, experiences of substance-related problems, and other relevant aspects of their history, including their medical history, psychiatric history, and family history. It represents the body of information that is required to make a diagnosis or appraisal of the patient, which in turn is the foundation for an intervention and ongoing management. That's my emphasis there. Now, psychologists, when thinking about assessment, hit it or emphasize a few different kind of points. So here's one that I think captures that sort of fairly well. And you can see the emphasis here is more on understanding the person more broadly, as well as the use of test scores and standardized tools. So this definition from Meyer and colleagues, an American psychologist, defines psychological assessment is concerned with the clinician who takes a variety of test scores, generally obtained from multiple test methods, and considers the data in the context of history, referral information, and observed behaviour to understand the person being evaluated, to answer the referral questions, and then to communicate findings to the patient, his or her significant others, and referral sources. Progress monitoring is something that's very similar, but is different in focus. So rather than just assessment and getting a clear picture of a person, it's understanding the changes that are taking place as a result of working with that person. And it's taken on much more focus in recent years. So the American Psychological Association defined it as monitoring of patient progress that may suggest the need to adjust the treatment. But more recent definitions of again, incorporated this idea of measurement more explicitly and the use of validated tools as part of that progress monitoring. And this has been in large part informed by research showing that we practitioners are actually quite poor at assessing treatment progress and particularly in missing deterioration. Bit of an optimism bias, that hope that can work so well clinically can also leave us blind to when perhaps people aren't doing as well as they could be. So definitions more like the one down the bottom there are cropping up more and more. So collecting session by session progress data using standardized rating scales and using feedback for clinical decision making. But it's not just us psychologists banging on about this. So the Institute of Medicine nearly 15 years ago noted a need for monitoring instruments that can validly assess response to treatment and that are practical for routine use in mental and substance use. The Group for the Advancement of Psychiatry also recommended practitioners implement standardized assessments of patient outcomes for mental health disorders, for which there is evidence of benefit. And 4 years ago, the US Department of Veterans Affairs have implemented a measurement-based care as policy in their substance use disorder treatment. And while they're not too specific in how organizations administer that, it does speak to this idea of regular brief questionnaires as an example. So what do I mean when talking about standardized assessments? Well, a good example is the audit, the alcohol use disorders identification test that everyone's familiar with, that initially started off as an interview schedule and then the more commonly used questionnaire. So standardized assessments are typically a questionnaire or an interview schedule that involves uniform administration and scoring to provide a common yardstick. It's inclusive and is designed to cover aspects that are overlooked in less formal clinical interviews. They're normed, which allows comparison to relevant peer groups. So that could be youth, drug and alcohol. It could be patients with alcohol use disorder. whatever's most appropriate for the kinds of individuals you work with. And the idea is that these tools would be less biased than just relying on a practitioner's memory or experience as to how severe these alcohol problems are compared to others. So what are the benefits of these standardized assessments? Again, they're fairly new on the scene and kind of don't fit with the classical image of what mental health interventions or clinical interventions involve. Well, a lot of research has gone into showing that there's only modest concordance between even structured diagnostic interviews and less formal clinician diagnoses. So they're tapping into different things. A clinician's impressions and diagnosis they might come to through the way they go about conducting an interview is not picking up on the same information as what you would get from a structured diagnostic interview. So in a large comparison of clinicians versus the CITI, the Composite International Diagnostic Interview, the inter-rater reliability was only 0.34. And similar reliability has been found with other diagnostic interview schedules. So the SCID there for DSM. So that's not to say that one's right and one's wrong, but they're drawing on different pieces of information and coming to different conclusions as a result. Now, this might come as a surprise, but the validity of psychological tests and standardized tests used in mental health and substance use are actually a lot better than you might think. So on a whole, their validity is comparable to those of medical tests. So there's a great big long list in that Maya publication there, but a few key ones I wanted to pull out and present there, comparing the validity coefficients of screening mammogram results and detection of breast cancer within 1 year, an R of 0.32. ALT results and detection of improved liver function, hepatitis C, 0.34. Pap smear and detection of cervical abnormalities, 0.36. And these are very commonly employed, perhaps even expensive, I don't even know, procedures. And yet when you look at the self-report measures there that you're more likely to see in mental health, the Achenbach scales, self-report scales on the child behavior checklist, coefficients around the same. Minnesota multiphasic personality inventory and ability to detect depressive or psychotic disorders. So they're in the same ballpark and they're not even significantly different when you look at them as a whole, medical tests versus psychological tests. So even though in large part they're all based on self-report, many of them may just be scribbles on a piece of paper, their validity is compelling. Other benefits include the ability to inform the selection of treatment. So again, the audit's a good example here where there are clear guidelines on a score on this tool means you should probably consider this kind of intervention. So for example, an audit under 20, an audit total score under 20, the recommendation is brief intervention involving advice, counselling and continued monitoring, as opposed to a higher score, which would involve a different form of intervention. And even though it's been hard in our field to come up with more precise or informative recommendations beyond that, you know, slowly as the evidence accumulates, we're getting there. So I was involved in the upcoming guidelines, Paul Haber's guidelines, and looking at the Psychosocial Interventions chapter. And there is some clearer guidance coming out now. For example, that motivational interviewing by itself is recommended more for less severe alcohol dependence if administered by itself, whereas cognitive behavior therapy could cover a much wider range of the severity of alcohol dependence. So it's hard to get more specific than that, but the goal is that if you can reliably assess, say, severity of alcohol dependence, that will help inform not only the intensity of intervention, but perhaps its form. And there's been some really great work showing that it can even inform treatment focus. So Patricia Conrod's group, looking at the Preventia brief interventions for kids. So this is prevention, early intervention work, mostly in schools, looking first at alcohol, but then looking at other substances as well, trying to delay the onset of substance use or problematic substance use in young people. Now, the content or the form is largely the same. It's mostly cognitive behavioral, but the focus of those skills it depends on or is based on your personality risk. So they use a tool, the Substance Use Risk Profile Scale, to identify kids who are at higher risk of getting involved with substances based on their personality. And the content of the program is then geared towards what is motivating those personalities to use substances. So for example, sensation seeking, if you're high on sensation seeking, the idea is that substance use may be a way to engage in some thrill seeking, some reward, then focusing on alternative ways of satisfying those needs is more effective than just a more generic approach in high-risk kids. And the prevention program's superiority has also been demonstrated here in Australia at NDARC by Newton and colleagues. So not just the kind of treatment or the selection of the package, but even the specific focus within that treatment. And again, in that case, the SERPs, it's just a questionnaire. It's just a validated, reliable questionnaire that bases the decisions on the nature of the content delivered to those kids. Other benefits include that just providing assessment and feedback on results is therapeutic in and of itself, even if you don't do anything else. So a meta-analysis looking just at assessment and feedback compared to a control condition. This was not substance use specific. It was across a whole range of areas. Found quite a respectable effect size of just giving assessment and providing feedback in terms of behavior change. A Cochrane review looking at motivational interviewing, randomized controlled trials in substance use disorder, found that by and large, motivational interviewing, this therapeutic intervention, really wasn't superior to just providing assessment and feedback by itself. And assessment and feedback is often a core component of motivational interviewing, but you can get quite a lot of bang for your buck just by doing assessment and providing feedback on that assessment to enact behavior change. So as a recap on some of the benefits of standardized assessments, we've got good evidence showing that they can capture details missed in clinical interviews, that their validity is comparable to those of medical tests, that they can inform treatment selection and even the focus of treatment, and that they can be therapeutic in and of itself. I guess the $64 million question though, and one that we don't really have a clear answer on yet, is does adding them to treatment that you would otherwise be doing actually enhance the outcome? Well, there's evidence accruing here that's looking very promising as well. So looking at mental health generally, a meta-analysis by Shimakawa and colleagues found that using progress monitoring during treatment, so with a general functioning measure, this was the OQ45, that included feedback, did increase the odds of clinically significant improvement at a large university-based clinic. So these were 4 large studies. I think some of the samples were in the thousands, but it was within the same university clinic that these 4 studies were conducted by the same research team. The participants were mostly young, female and Caucasian university students. There was a mix of diagnostic presentations and it wasn't substance use specific focused, the population studied. But nonetheless, odds ratio 2.55, that's quite impressive for a small addition to business as usual. What about in substance use? Well, there's not a lot been done in this space, but there was a good study conducted in 2012 by Christoph and colleagues. So this involved 3 sites and a total of 304 substance use disorder patients. It was a non-randomized controlled trial. So they were evaluating an implementation of progress monitoring using that same tool, the OQ45, which is a measure of general symptoms and functioning, but they also added in a couple of drug and alcohol items, 1 each for alcohol and for substances for monitoring. So it was limited, but it was a building on the OQ45. And what they found was that progress monitoring, session by session, with feedback, did improve outcomes for alcohol use. So statistically significant there, and you can see that the sharp drop in the line there, that top graph. A similar impressive looking effect for drugs as well, drugs used, but they didn't quite reach significance. The p-value just didn't quite hit 0.05. So in a substance using population, it's a non-randomized controlled trial though, also some promising results there of this fairly simple addition to a standard practice. So perhaps enhancing outcome when added to treatment, maybe, it's promising, an asterisk there with a tick. There's some promising initial evidence, but not as firm an evidence as backing those first 4 points on the slide there. So given that evidence, we're all regularly using these kinds of tools, right? You know, we see the evidence, it's there are plenty of these tools available. We're all using them, aren't we? No, we're not. Why? So very few, even psychologists who are perhaps more likely to be championing these kinds of things, we love our questionnaires, even they don't use them very regularly. So less than 10%, this is US data, find that psychologists use standardized assessments regularly in psychotherapy. They're more likely to use them if the goal is to make a diagnosis. Australian data as well as US data shows that for monitoring of treatment progress, only about 1/3 of psychologists use them regularly. Again, less data in the alcohol and drug sector, but there's something there. So in the US, they found that while alcohol and drug practitioners do commonly monitor substance use changes in their sessions, about 2/3 of sessions, the quality of that assessment is acceptable or adequate. So imprecise, general sort of reads on whether there's been any change in sort of substance use and the nature of that change. Another interesting result was looking at craving specifically. And even though the majority of practitioners, 99% assess craving in some fashion, and over 80% think it's important to consider and to know about when in developing treatment and planning treatment, only 5% of practitioners use some kind of standardized assessment for craving. And some of them are quite brief for craving as well. So again, it kind of highlights that there's a recognition of the importance of this, but we're just not regularly doing it. And that's mostly for practical reasons. So while most practitioners see value in using standardized assessments, time barriers are rated as the most important barriers to implementing them in practice. So taking too long to administer and score is usually the #1 rated barrier. Adds too much paperwork is another one, takes too much time. And, you know, most practitioners, very busy. You know, their caseloads are larger than they should be. Oftentimes they don't finish their day when they intend to. There's already a lot of work to do, a lot of paperwork that's already part of the job that's required. Adding on even another small piece of paperwork is a big ask. So it's completely understandable that it would be those barriers that are the primary ones. Now, they're not the only ones. I mean, there are also attitudinal barriers. But when you control for the time barriers, they're not predictive of behavior. They're not associated with actual behavior. It's primarily those time barriers. But, you know, some people do legitimately feel that these kinds of tools are not particularly helpful, that a simple measure can't really capture what's really going on in treatment, and that even that they can't tell me anything that I can't already learn from talking to clients. So there are attitudinal or perhaps more philosophical barriers as well as time barriers. So how are things here in Australia? So we've recently conducted a survey of Australian alcohol and drug practitioners on their assessment practices, an online survey of 99 Australian alcohol and drug practitioners Australia-wide. And we got a fairly good mix there of professions, psychologists, counsellors, social workers, and some medical professionals as well. Mix of APRA registered professionals and not, qualification, decent sort of mix there as well. So not particularly biased in one direction or another. A diverse number of years of practice with sort of humps at the very experienced end, 20+ years, and in the more inexperienced end, 0 to 5 years. And fairly good spread of workplace settings there as well, with the majority coming from community practice settings. So when we assessed Australian alcohol and drug practitioners, we found that the majority, just over half, did agree or strongly agree that standardised assessments are reliable and valid. So one of the subscales there, the ASA psychometric, it's got a whole bunch of items and you average the score across those items. So you can see there the mean was sitting just above neither agree nor disagree on that scale. We found that those with higher academic qualifications tend to have more favourable views of the reliability and validity of standardised assessment tools. But things start dropping from here. So only a third agreed or strongly agreed that for initial assessment, standardised tools provide benefit over clinical judgment alone, with psychologists tending to see greater benefit compared to other professions. And then things dip further still, again, looking at those practical issues, that for an initial assessment, only less than a quarter agreed or strongly agreed that standardised assessments are feasible to use in practice. So pretty good confidence in the reliability of the tools, but then is it better than clinical judgment? Is it feasible? So it starts really dropping off. And we found that practitioners working in both inpatient and outpatient services tended to see them as more feasible than those in community practice or those working exclusively in inpatient services. So that was for initial assessments, getting an initial sort of picture of the case that's in front of you. But what about for monitoring of treatment progress? So we asked, how often do you administer standardized progress monitoring measures on average? And we found that nearly half the sample did it with a reasonable degree of regularity, either very frequently or once a month, nearly 50%. Just under a quarter never administered them. Interestingly though, when we asked that same question later on, asking how much they would like to administer them, over a third of the sample said they would prefer to be administering them more often than they currently do. So again, that kind of fits with that picture of there's this desire and appreciation for the value, but there's just something that's getting in the way of translating that to action. So a majority of practitioners agreed or strongly agreed that for progress monitoring, standardized assessments are useful in treatment planning. And those with less than 5 years of experience saw them as significantly more useful than those with more experience. Just under half of practitioners agreed or strongly agreed that they're feasible to use in practice. So these tend to be the briefer session by session sort of monitors of progress than the initial assessment. So seem to be more feasible in practice. And interestingly, APRA registered practitioners thought they were more feasible, whereas those in community practice felt they were less feasible. So again, an insight into different contexts. It's maybe a bit more difficult to actually use these tools in the kind of work that they do. Now, interestingly, your attitudes or perspectives on all of those things were related to quite a significant degree to your general attitude towards evidence-based practice. Now, as a sample as a whole, we were pretty good on this front. So we were a full standard deviation higher in positive attitudes towards evidence-based practice than the original normative paper developed in the US on quite a large sample. So full standard deviation larger. We've got more positive attitudes generally towards evidence-based practice. And that attitudes towards reliability and validity, benefits over clinical judgment, feasibility, were all associated with our general attitudes towards evidence-based practice. So it's hard, there are different ways you could read that, but I do wonder if part of that is, if we're feeling too busy and it's too hard to put these things into practice, it's easier to go to sleep at night knowing that, it probably hasn't made much of a difference and I'm pretty good at what I do anyway. I don't think any major things would have been missed. Possible, that's one interpretation of some of those results. So pulling all that together, results from our recent survey as well as the previous literature more broadly, most people agree that standardized assessment tools are reliable, valid and useful in treatment planning. 2/3 though are still not convinced that they provide benefit over clinical judgment alone. And to be fair, the evidence is probably weakest in that domain compared to the others. So it's not as if people are kind of resistant, you know, you couldn't really say that that's an unfair perspective to have based on the current evidence. Majority also not convinced that they're feasible in practice. So this is a big one. 77% for initial assessment, 58% for progress monitoring, but a sizable proportion of us would like to use them more frequently than we do. So what can we do about this? Well, those seem to be the two big things there. Incremental validity, providing or locating evidence for that or against that, as well as improving feasibility in practice, would be most likely to lead to behaviour change amongst us. So what to assess then? You can get a questionnaire to assess just about anything. You know, it's one of the benefits and the curses of psychological research, I suppose. You know, we've got a questionnaire for everything. So the obvious things: consumption, substance use consumption, and patterns of consumption, the severity of dependence or diagnosis, some kind of measure of the severity of the problems a person's facing. And again, most people agree craving's particularly important. Patients agree, and it's a recent addition to the DSM as well in recognition of its importance. So those are all pretty obvious things that you'd want to be measuring. But to hit on that incremental validity, perhaps including some mechanisms of risk or change, some potential early warning signs. So a lot of it, in the setting that I work in, a lot of the programs that we offer are abstinence focused. So the goal is abstinent. Patients can lapse, but the goal is abstinence. So if people are starting off pretty well, maybe there's some craving that you can detect, but if they're not drinking or they're not using, are there any other indicators to see whether there's some worrying periods ahead or whether what you're doing is having any change to that? So some mechanisms, some reliable mechanisms of change would be helpful, perhaps with that incremental validity question. So again, what to focus on? Well, one approach you could take is to look at, well, the evidence-based treatments that we have tend to be focused on social cognitive theory. So what about that? So two core components of social cognitive theory are drug refusal self-efficacy and outcome expectancies. And there's quite good evidence for self-efficacy as a predictor of change and long-term outcome, as well as something that changes in treatment. So what is drug refusal self-efficacy? Well, it's based on the notion that people are more likely to engage in behaviours when they believe they're capable of executing those behaviours successfully. So based on Bandura, if I think I can do something, if I think I can resist cravings, I'm much more likely to try. And when things get difficult, I'm much more likely to persist, which increases my odds of success as a result of that. So an assessment of a person's confidence is a predictor of how well they fare in future. And that came out in Project Match, looking at alcohol use disorder treatment. It was one of the two robust predictors of long-term outcomes, regardless of treatment. And a more recent systematic review looking at cognitive behavior therapy specifically identified self-efficacy and changes in self-efficacy as one of the more promising mechanisms of change. So maybe that's something we might want to measure. Impulsivity might be something else as well. So I was talking about prevention and Patricia Conrod's work in prevention before, and it was the impulsive traits in particular that were kids more likely to be high risk, and that tailoring your intervention to that led to better outcomes. And impaired control is a core feature of substance use disorder itself. And we've got a lot of evidence now showing that impulsivity is a robust predictor, even well before substance use starts. It's a robust predictor of getting into trouble with substances and developing real problems with them, more likely to drop out of treatment prematurely or respond poorly to treatment. And even some laboratory work that my team's been doing recently has been demonstrating causal associations between impulsivity as well as heavier drinking in young people. So impulsivity, when thinking about substance use, is best to conceptualize as a two-component trait. One component reflecting more reward sensitivity or the strength of the impulse that maybe you want to resist. And the other, which we've labeled rash impulsiveness, others call disinhibition or just impulsivity, reflects more that ability to inhibit an impulse regardless of its strength and not do something that maybe will lead to negative consequences. Now, regardless of the labels you use or how you measure it, there's a strong genetic component, and these are pre-existing features. So they might be mechanisms of risk that's worth getting a picture of during an initial assessment as well. So there's been some impressive evidence on just how early you can measure this and it predict future problems there. Terry Moffat's group demonstrated that in a paper published in the Proceedings of the National Academy of Sciences. And some of our more recent work has been looking at, well, okay, how is it that impulsivity makes you more likely to use? And we've been looking at what some of the downstream effects of being genetically predisposed to being impulsive has in terms of your thinking, your behavior, your experience of craving, and so forth. Those are things that we're much more likely to be working on in treatment. So building on social cognitive theory, we've kind of I guess, add on some of the biology or predispositional effects and developed a biosocial cognitive theory when looking at substance use. So specific components of impulsivity, predicting specific beliefs or domains of cognition that are more likely to be the focus of treatment and then leading to substance use. And we've accrued a number of replications of that general model I just showed you, mostly in alcohol, but also more recently in cannabis use and patients referred for cannabis use problems. And we're looking at stimulant users at the moment now as well to test that. So perhaps with a bit more of a focus on some of those mechanisms of change, we could hit that incremental validity a little bit more on the head. What about feasibility? Now that's a tough one. You know, these tools, standardized assessment tools have been around for a long time. Tools like the OQ45 and other electronic platforms have been around for a long time, but they're just not quite translating into the clinic as easily as perhaps they should be. They've been around for many years. So what could we do about that? Well, we're talking with practitioners where I work, we identified some key features these things needed to have. First of all, they had to be low cost or no cost. So, you know, if you're working in Queensland Health or in a public service or anywhere really, I mean, cost is an issue. And if something's expensive right off the bat, it's probably going to be dismissed. Something that needs to be modifiable, easily modifiable. There's no one way to do an assessment. And there's no one right way to do it. And as the evidence changes, you want to change your focus as well. And so to do that and to keep it low cost, it can't be something that requires an IT professional or a programmer or coding. Again, that becomes a cost issue. So we wanted to develop something that was low cost, easy to implement, and that would allow you to administer an electronic questionnaire or assessment to someone, maybe while they're in the waiting room, have that instantly scored, benchmarked against norms for a clinician to see, and for you then to immediately be able to discuss the results with them. So the instant assessment and personalised feedback system, the IACS, is what we came up with. And our first foray or trial of this new sort of low cost modifiable approach, we conducted an open label feasibility RCT. And that's currently under review. So we looked at 87 young cannabis users who were referred for a brief intervention by the police. So we had one session with them for 2 hours, involved an assessment, an informational video on the health effects of cannabis, and some motivational interviewing. So we randomized them to either assessment as usual, which involved just pen and paper questionnaires, or those very same questionnaires, but in this new electronic format that was instantly scored and benchmarked. What measures do we include? Now, we benefited from the fact that because we were already using these measures, it was the same tools in both conditions. It was just whether they're administered by pen and paper versus via the new electronic system. So the measures were informed by biosocial cognitive theory and the empirical evidence I was discussing before. So we looked at cannabis dependence severity, craving, outcome expectancies, refusal self-efficacy, general mental health or psychological distress, as well as impulsivity. And what we found was that even just within that 2-hour session, that simply providing assessment information, ensuring it was scored and benchmarked, and in a visually engaging way that made it easy to discuss with patients in that very brief amount of time you have, did result in greater changes in motivation to want to do something about their cannabis use in that once-off consultation. Medium effect size, and we asked them a whole bunch of questions about the assessment itself, aspects of it, the patient's views of the assessment. And the differences between the conditions that came out was a better understanding of my results when they were explained to me. So rather than just a verbal kind of, you're over this cutoff, I'm more severe than that, presented visually, clearly, on the screen there to talk through, ask questions about, and also they felt they understood better how their use compares to other people. So in this particular trial, we compared their scores, not just to other users in treatment seekers, but also other non-dependent users. So they could get a picture of sort of where they sit there. So in the example on the page here, someone's sitting in between a non-dependent user and someone who's already seeking treatment. So, you know, you could frame that as discussing, well, maybe now's a good time to do something about this before it becomes a big problem. So, you know, it was up to the clinician how they wanted to use that information to kind of frame the motivational interviewing component of that intervention. And it was cost effective as well. So it saved quite a bit of staff time in scoring those assessments and entering the data that was written out by hand. So we estimated it was about maybe $15,000 in staff admin time that was saved by using that system. So, okay, that's kind of promising as a feasibility study, but would a system like that work in routine clinical practice where you're delivering treatment over an extended period of time? So we set out to do that for our alcohol CBT program. So we wanted to modify that system for that purpose, train the practitioners in the use of it, and evaluate its impact on whether people were more likely to use these assessments. So a little bit of a description of the setting. It was an outpatient unit of a large public hospital, the Princess Alexandra Hospital. All patients get an initial medical assessment and diagnosis first. Then if they're interested, then they can be referred to our 12-week one-on-one CBT treatment program that's delivered by one of 10 part-time clinical psychologists. So it's the clinical psychologists we're monitoring here. And we wanted to do an audit of assessment administration practices 1 year prior to the rollout of this system and then 1 year post. So 2,500 treatment sessions was covered as part of the evaluation. Again, measures were informed by the same theory, looking at alcohol dependence severity, craving, expectancy, self-efficacy, psychological distress, and impulsivity. That was all part of the initial assessment. For session-by-session progress monitoring, we just look at self-efficacy, craving, and drinking. So there's a screenshot of what the initial assessment kind of summary of results display. You've got the DAS up the top, some of the suicidal ideation items from the GHQ there underneath, and then benchmark scores of where people sit compared to other patients, Australian alcohol outpatients on severity of dependence, expectancies, craving, impulsivity, and self-efficacy. For progress monitoring, this is what the display looks like here. So like I said, we're just tracking drinking, craving, and self-efficacy to keep things brief. 5-minute questionnaire they can fill out in the waiting room before the session starts. And this is an example of someone who's done the full 8 sessions of the program and 4 follow-up sessions. So it also marks when there's been a change in the alcohol pharmacotherapy the patients have taken. So in this example, having stopped taking a camprosate at session 5-6. And you can see here that over the course of treatment, there was a gradual increase in self-efficacy across the board. Craving also trending down across the course of treatment as well. There was a lapse during the follow-up period. And you could see there that that coincided with drops in self-efficacy and a bit of a boost in craving post that. So that kind of updates itself as each session progresses for the psychologist to discuss with the patient. So providing access to this and showing them how to use it, did it affect how often people administered assessments? Yeah, it did. So when we were still paper-based, only about 1 in 2 initial assessments involved some of those paper assessment questionnaires I mentioned before that the clinical psychologist administered. Up to nearly 90% once it was electronic. You remove the admin costs and the practical barriers, it's much easier to use. For progress monitoring, session by session monitoring of progress, that showed an even larger increase. So again, as per international and national data, it was only about 1/3 of people using them, and then that jumped up to 84% of sessions they were being administered to. So providing a low cost, easy to modify tool, increased compliance with evidence-based practice around assessment. There was very positive response from practitioners, in this case psychologists. There were some hardened staff, some who did come around, others have not come around, not yet anyway. So maybe more attitudinal barriers than practical barriers. There's still this question of, can it improve outcomes over what they were doing anyway? And that's what we're looking at next. So we did see just in that evaluation that there was an increase, a 60% increase in program completion rates, so people doing 8 sessions, but we're still yet to dig into the drinking outcomes data to see if treatment was actually more effective in terms of maintaining abstinence, reducing drinking when it occurs. So coming back to that summary there, we're slowly building perhaps some evidence for point number 5 there. And I guess the purpose of the tool we've developed is not to reinvent the wheel, but just to provide a platform that can make it easier and remove some of those practical barriers. And we've suggested some measures that we think are important based on our reading of the evidence, but that's not the only way you can use the thing. So we've developed a website and an instruction manual for how you can build this thing. It just runs on the Google G Suite platform, which is pretty cheap to run. You can get yourself a private sort of enterprise account for fairly cheap. It's really all just run through Excel formulas and integrating of survey data into that. So the way we run things, it's just the test scores that go into the cloud and get scored and benchmarked. Even though you can modify your system so that it's HIPAA compliant and compliant with Australian privacy law. We've done that anyway, but not even age, gender, things like that go into our system, just the test scores. So if you want to dabble around with something like that yourself, go check out the manual on the website there. We've provided sort of a base kind of system that we think could work in most settings, you know, but the screenshots I was showing you before were ones we built specifically for our service, modified on that. So we put in instructions how you yourself could modify that to suit your own needs, how to add your own questionnaires or take out ones you're not interested in. And there are no other costs aside from your subscription to the G Suite platform that runs the thing. So the hope is that a low cost, easy to modify system will allow people to kind of build their own or just go with the one we've prepackaged. It's just an alcohol one we've got up there for the moment and kind of get you started on testing out some of these things. So in conclusion, even though the focus has been on standardized assessments and the utility of standardized assessments, the answer to the mystery of looking through the glass darkly is not that you'll see a number. 42 is not the answer to solve all of a person's problems in their life, including substance use. So it's not designed to be advocating for the use of these tools as a replacement for practitioners. I mean, nothing can replace the clinical decision-making of a qualified professional. But I think what they can do, and what there's very good evidence for, is that they can help cover our blind spots. And particularly when we're working in a busy environment, and we've all had scenarios where maybe, you know, we've done a less than ideal assessment for whatever reason, and these tools can help cover some of those blind spots. And I think that was summarized in this quote here from Meyer and colleagues. So they state, here that assuming no data can be deemed invalid or ignored, then the assessment clinician must conceptualize the patient in a way that synthesizes all of the test scores. The careful consideration of multi-method assessment can provide a powerful antidote to the normal judgment biases that are inherent in clinical work. So I'd just like to finish off by acknowledging all the people involved in this line of research and in the development of the IACS, who are listed there on the screen, as well as our funding sources, the great staff at the Alcohol and Drug Assessment Unit, who had to suffer through some horrible prototypes of the initial versions and changes in our workflow practices. Thank you.
Thank you very much, Matthew. Nice presentation and some useful information. We've got several questions come through, so if you're happy to stay with us, I'll work through a few of them. The first one, we had several people asking, in the study that you were doing, what was the age range of the young people that were involved in that study? Yeah, good question. So the age range was, I think the youngest was 16, and it went all the way up into the 60s. I'm not sure if we had the range on that there. The mean age was the mid-20s. No, we don't have the range. So mean age 26.41 with a large standard deviation there of about 10. So pretty young, and being through the QIDI program, we had all sorts. Some were high school kids who were just on their way to a festival, who'd maybe never smoked cannabis before, but were just apprehended, all the way to those who'd been smoking for most of their life, got apprehended. And so there was quite a diversity there, but they tended to be young. And obviously your focus was on alcohol, but one of the questions we've had is how transferable do you think it would be for other substances? Yeah, good question. So the first prototype was focused on cannabis, just in that once-off assessment. That's worked well, we thought. In alcohol, it's worked well. We're now rolling it out for our stimulant CBT program. I think because there's initial assessment and progress monitoring, I think for any situation in which you want to conduct an assessment and use some tools, and you have validated tools for that substance, you could use it for. So again, it's not doing anything different, but just making it easier to access that information. I think for the progress monitoring stuff, any kind of psychotherapy or counseling over an extended period of time can just help you see those changes. And I guess on that, is there any evidence out there as to, you said that obviously there's some reluctance initially with clinicians to actually use these tools on a regular basis. But it seems that if they are used, the evidence is there that it ends up being a positive outcome. Is there evidence about how often they should be used during those, during the treatment process, as it were? Yeah, that's a really good question. I don't think there is actually good evidence on what the right kind of frequency amount is. I mean, my recommendation would be if it's 5 minutes and it's simple enough, just try to do it as much as you can. Yeah, but that's a good question. I'm not aware of any research that's pinpointed what a good frequency is. It was kind of linking in with another question we got, which was, again, you've done some investigation as to the clinicians' impression of their use and how valid they think they are and how likely they are to use them. Again, kind of testing your knowledge on research a bit, I apologise, but is there any evidence on the other side of the coin from the patient's perspective? If something's repeated, do they find it still valuable, or do they kind of have that impression that the clinician's going through the same routine every time? You know what I mean? Great question. No, great question. So some of what I didn't cover in the talk was we did collect some feedback from patients in those studies, and it's positive by and large. We do sometimes get in our alcohol program older patients who just don't like anything electronic. So we'll offer to give it to them pencil and paper. That's fine. And there was a study that I was looking at just the other day showing that in young people, this is a US study, in young people, I think in primary care, that their preference is for these questionnaires to be delivered, not just electronically, but in the waiting room, not in the same room as the practitioner. They felt more comfortable disclosing their substance use in that context than in the room with someone. Or even verbally. So I think it's largely positive, assuming the technology doesn't get in the way. Sure. I know obviously the answer is you're going to recommend your tool. That makes perfect sense. But somebody's asked, what other tools would you recommend for, particularly for alcohol? They asked, if somebody has alcohol dependence, what tools would you recommend to you?
Yeah, so if you're looking at severity of problems, I mean, the audit's a great start, but the severity of alcohol dependence questionnaire has been around a long time. And I think for your more moderate to severe presentations, that gives you a better reading on how things are. I think cravings always important. There are a bunch of craving measures out there. Our measure, the MACE, is short, 5 items, but people are looking at developing even shorter ones, like 3 items. So for any construct you think's interesting, chances are there are multiple measures of it. See what's out there, and what the evidence is there for it.
And I'm guessing I've just been handed another question, which is pretty much the same one, but looking particularly at opioids. So I'm guessing the same, see what's out there and try and incorporate into practice and see how beneficial it is.
That's right, yeah. So we don't see many opioid patients where we work, but there are tools out there for quantifying dependence and craving and other things as well.
Perhaps a difficult question. We're talking about successful outcomes, and you said that you work in a predominantly abstinence-focused treatment facility. So if abstinence is your goal, how do you measure success? Which is obviously the $6 million question that we regularly get asked in our business.
Yeah, so that's a really good question. So if we're talking about our evaluations of the program, it's probability of abstinence at any given presentation, how low their drinking is when there's been lapses. Clinically, though, when you're working with someone, I mean, they're a part of our program because they have that goal as well, abstinence. If they want controlled drinking or something else, we point them to plenty of programs that offer that too. So that's their goal too. But even those who do struggle with achieving abstinence, most of them show sharp reductions. And if they're happy when they finish, we're happy. But I guess we're always striving for that kind of gold standard, because we do see a lot of people who just really won't. Controlled drinking is just not going to be for them.
It's difficult for some, for sure. Sorry, no. There was another question. Oh yes, somebody asked specifically. You mentioned in your project about a video that you showed, a cannabis video, and somebody has asked, is that one that you developed, or is that one that's available for other people to look at?
No, that one's been around for a little while. I think that was one developed as part of the QIDI program. So it's got interviews there from what I think it's the early 2000s, but it looks older. But there's interviews from a fairly young looking Professor Wayne Hall, Professor John Saunders, some former police officers. Yeah, I can't remember who developed it, but it was for use, I believe, as part of this particular program in Queensland, the drug diversion.
Cool. I think my final question is, you mentioned that there's quite a significant improvement, shall we say, if somebody just has a brief assessment and then they're fed back that the results from that assessment. Just doing that alone can have a significant impact on motivation and outcomes. Is there, and again, a $6 million question, I guess, is there any evidence as to how long that brief increase in motivation might be, how long it's sustained for? Is it simply that they feel better and feel more positive when they leave, or does it continue for a period of time?
Yeah, that's a good question. So some work that's been done on that with alcohol. This was looking at a non-clinical group. I think it was mostly university students, Jim McCambridge and his group. They did a couple of studies showing if you just give someone an audit, just filling out an audit, their drinking and their hazardous drinking drops over a period of time. I think it only lasts for a few months though by itself. But that's still a valuable, that can be a valuable part for somebody's life. Absolutely. And I guess it depends on the severity of the problems that they're dealing with. I mean, if it's just some heavy consumption and some hazardous use, but there's control there, but maybe just not motivation to cut down, just some of that information could provide a lot of clarity. Whereas I think if the substance use is being driven because it's the only way someone knows how to deal with their anxiety or their depression, you can present that information, but you wouldn't expect it to be all that's needed to kind of address that different ways of regulating mood or dealing with anxiety are going to be needed. So I think it depends probably in large part on the severity, and perhaps that's what that evidence before with motivational interviewing was kind of showing, that it works very well in the short term, and for less severe presentations, I would imagine that the assessment and feedback that's a big part of that is probably going to be similar.